The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Welcome to Lymphcast, the gathering place for physicians, healthcare experts, and special guests. We dive into the world of lymphedema, venous disease, and other related disorders, exploring their impact on your daily life. So settle in, unwind, and join us as we uncover everything you need to know about lymphedema and related conditions on our engaging show Lymphcast.
Today's Lymphcast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Greetings and welcome to Lymphcast, our show all about lymphedema and associated disorders. Episode 30 tonight, if you can believe that. We do want you to check out our website, lymphcastnetwork.com, and everything is there for you. Also, if you have any questions for the panel, please send them in. I'll give you the email address now. It'll be in the show notes as well. hello@lymphcastnetwork.com. Easy to remember. hello@lymphcastnetwork.com. Let's go ahead and meet our panel tonight, and then we'll kick things off. From Arizona, Dr. Monica Glavitsky. Greetings, Dr. Glavitsky. How are you?
Very well, thank you very much. And I'm so happy to be with the team again, and happy for this new adventure with our guest.
All right. Glad to have you here. The founder of this show, also the founder of VitaSupport MD. They make Vein Formula 1000 and Lymphatic Formula 1000. From New Jersey, physician surgeon, Dr. John A. Chuback. Hello, Dr. Chuback. How are you?
Hi, Paul. I'm doing well. Good to be with you again. We have a good show planned that I think is going to shed some light on some important subjects.
Yep. No, I fully agree. If you don't mind taking the honors, why don't you bring our special guest in? We'll have her tell us about herself, and then we'll get going with the questions.
Sure. Today's guest is Elizabeth Coll, and Elizabeth and I work together currently. I'm very fortunate to have her as a part of my clinical team here at Chuback Vein Center in northern New Jersey. But Elizabeth and I have known each other a very long time, although we both look, unbelievably young and great for our age. We are, like everybody else, aging, and we have known each other, I would say, more than 25 years. We've known each other since I was a general surgical resident in New Jersey. In my second year of residency, we met when Beth, as she prefers to be called, Beth was critical care nurse in the cardiac surgical intensive care unit. And ironically, I went on to become a cardiac surgeon, as many of our viewers know. But that's where we first met. We were both very young and relatively inexperienced, but learning and growing as young professionals. And little did we know that more than 25 years later, our paths would cross again. And our paths did crisscross a little bit over the years as we would see each other again at meetings and had some discussions of even employment many years ago. But Beth has had in many ways a parallel career to mine as a nurse and as a practitioner, because we both started basically in cardiovascular surgery, hospital-based surgery, critical care-based surgery, lots of life and death stuff, lots of very, very sick people, lots of nights and weekends and holidays, and, a very strenuous part of the medical career and surgical world, perhaps the most strenuous element that medicine has to offer, being involved in open heart surgery for years. And then we both sort of, I suppose, saw the light, independently of one another, and over time gravitated toward this field of especially chronic venous disease and chronic venous insufficiency. And as that field has sort of developed, lymphatic problems, lymphatic disorders as well, wound care, and all of the associated aspects. So I'll read a little bit from Beth's CV. I have a little synopsis of it here. Besides being, a registered nurse who had her bachelor's degree at the forefront of her career when I knew her initially, she also became an advanced practice nurse, an APN, in phlebology, and she has contributed significantly to that field over the years with activity and involvement in several professional organizations, and has been involved in teaching and writing over the years in that field. She also went on to get her master's degree and her doctoral degree at Columbia University and Rutgers University to enhance her clinical skills and her research skills and her leadership skills. And so she's obviously a very highly educated woman and highly decorated person with a lot of experience now in vein care, getting close to 20 years of experience in vein care, having worked largely in private practice in New Jersey. And I've known several of the practices that Beth has worked in over those years, and we had some clinical interaction amongst patients and things over the years. And as things have unfolded, finally, at this stage of our career, sort of at I would say, the prime of both of our careers, we came back together and joined forces and now work together on a daily basis here in my practice, as I said, in northern New Jersey, just outside of New York City in Bergen County. And she's been with me a few months now and is doing exceptionally well and is an extremely competent and capable practitioner. But I think that it would be really fascinating to talk to her about not only many of the things that we normally discuss on the show, which is the management of people with venous and lymphatic disease, but I think both for the public and for practitioners who may be listening, I think what has been for us so far on the show, I believe, a special perspective of the nurse practitioner and what has been sort of traditionally called the mid-level practitioner. I don't know if that's an outdated term or is becoming one, probably is. But I think that it's an important perspective and a field that is only going to grow over the years in the United States, and it has been growing in leaps and bounds already. So that's our guest for today, Dr. Beth Coll. And welcome, Beth. Thanks for being on the program.
Thank you for all those very flattering words. I appreciate it. I'm really happy to be here.
Well, they're complimentary, but they're not flattering because they're all true, and you've earned them all. So they're well deserved. Since I've spoken already so much, I think that I'm going to perhaps pass the baton right back over to our dear colleague and friend, Dr. Monica Glavitsky, and see if she has any interesting questions she might want to open the broadcast with.
Yeah, absolutely. I always have a lot of questions. That's how it is. What I would like you to explain to our listener. So, first of all, how somebody became the nurse practitioner so experienced as you are in the field of venous and lymphatic disorders. So what is the training? What is the help that you can have with some formations, degrees, and so and so?
So I, like Dr. Chuback said, I started in cardiovascular surgery as a staff nurse, and then went to Columbia to get my nurse practitioner certification and my master's degree.
So I'm sorry. So nurse practitioner, how many years you have to fulfill education, training, and so on?
So after the bachelor's degree in nursing, a nurse practitioner is a 3-year program with a clinical component where we get advanced training. And in my case, my program was as an acute care nurse practitioner, a hospital-based nurse practitioner. We had additional advanced clinical training for things like inserting central lines, chest tubes, suturing, emergency care, critical care, vasoactive medications, that sort of thing. So that was my advanced clinical training as a nurse practitioner.
Yes, yeah.
Through Columbia. And that was many years ago, 1998. So, and then around 2004, I was working as a nurse practitioner in cardiothoracic surgery and vascular surgery. And I was approached by an interventional cardiologist, actually, who wanted to open a vein center. And I didn't really know anything about it, but at the time it sounded very interesting to me. And so he and I went and spent a month in Florida training at a vein center down there, and came back in 2004 and got up and running in his practice. And that just drew me in. I loved it. And I became very actively involved in what was the American College of Phlebology at that time.
Good.
And I really enjoyed the imaging component. So I started doing my own ultrasounds and pursued my certification as a registered vascular technologist. And so for a while, I was doing all of the sclerotherapy and the venous imaging, all of the vein mapping, all of the rule-out DVTs, and really just becoming well-versed in venous anatomy and pathology and imaging. And I enjoyed that tremendously. And I think that allowed me to competently make the leap to performing ultrasound-guided sclerotherapy, which I've done for many years. And I really just, I liked it a lot. And venous disease and lymphedema go hand in hand, as we all know. And of course, wound care is an essential component of that. So those are the three areas that I have concentrated my career on for the last 15 years: venous disease, lymphedema, and wound care.
Well, that's fascinating, for me. And apparently I can see that, John, you are not the only cardiologist who switched to veins. Is that epidemic or what?
Well, I think it was a bit of an epidemic. As you know, I'm a cardiac surgeon, not a cardiologist. There's a obvious distinction between the two. But the person that I initially trained with and had exposure was Ron Bush, who was also a board-certified cardiovascular surgeon. So I think that at the time, back in the early 2000s, I went right around the same time, 2004, I didn't spend a month. I spent a day with Ron Bush, but I was a fast learner. Of course, at that time I was doing open heart surgery, so I didn't have the time to do any lengthier training, but it was a great experience and did a lot of studying outside of obviously that time that I spent with Dr. Bush, and for a period of time had open lines of communication with him to ask questions and gain counsel and advice and things like that. And for many years, I was practicing cardiovascular and thoracic surgery alongside veins, and I slowly but surely built the practice up to a full-time vein center. But I certainly didn't flip a switch and do that overnight. So we all learned as the field was progressing, and as new techniques were being introduced, and we grew together. And it was funny, it's just interesting that Beth and I were doing that sort of in parallel, but not together. And I think that the fact that she became an RVT and I became an RVT was very valuable indeed, because I think that in order to be truly competent in this field, ideally the practitioner should be scanning and really feeling comfortable with the probe in their hand and knowing what they're looking at, and not having to be really assisted in a crutch-like fashion by a technologist in order to do all of those things. And that has been one of Beth's strengths in our practice, is that she's completely autonomous in that way. I've had some other mid-level practitioners who don't have her strength of background try to work with me, but they were never really able to get to that next step, largely because their ability to scan and ultimately make that leap from just a purely diagnostic scanning person to the interventional scanning person is a bit of a leap. And I think it's an interesting subject. We talk about it quite a bit, that you're looking at a two-dimensional image that's remote, and you're working in 3 dimensions close to the body. And it's not for everybody. Not everybody can make that leap of being able to work in 3 dimensions without looking at their hands. And so you're looking off into the distance in a 2-dimensional plane and working in 3 dimensions. And Beth obviously has been able to master that and is very, very capable. So that was a great accomplishment on her part. And it was one of the reasons that I had her join us here and help with all of our clinical work. It's a great skill set to have.
And to add to what you're saying, my philosophy, and I'm sure it has been yours too, is that we don't treat patients based on ultrasound reports. We treat patients based on what we see. We don't treat a report. We treat a patient.
Yeah, that's critically important.
Fully. But interesting point that I wanted to tell about how different healthcare can all over the world, because actually, at least in Europe, but also in many other than European countries, the treating physician is performing the ultrasound, and there is technicians are not doing that. The technicians are much more in the more sophisticated, examinations like a CT scan or some others, but not with the vascular diagnosis with ultrasound. Every single physician in Europe. How interesting!
Yeah, right? It's very interesting. And here we have a combination. Some physicians can, and some physicians can't, and some physicians have greater skills in terms of reading and interpretation. Those with a radiology background, for example, may have a very strong ability in reading and interpreting images, but some may have essentially, if they're not an interventionalist especially, have no experience holding the probe and as we say, mastery of knobology, knowing how to adjust the machine and all of those things. So those are additional skills that we both studied. And as you know, Monica, I have my RPHS, my RVT, and my RPVI. And
this is a lot of letters. Maybe you should explain. Yeah.
Well, RVT is registered vascular technologist, and Beth is also a registered vascular technologist. That's 2 examinations that you have to take.
Yes.
RVT, you have to take a clinical examination and also a physics examination so that you're understanding the physics of ultrasound and so forth. And then RPHS is registered phlebology sonographer, which is specific to phlebology. It's sort of, I think it was created almost as kind of a mini credential for people who were not doing arterial work so that they could learn venous ultrasonography faster, and which is in some ways, I think, less complicated than arterial ultrasonography. So I had that because we were doing vein-related work. And then the RPVI, which is a newer credential, which is for physicians only. That's the registered physician vascular interpretation for MDs who are not necessarily radiologists, but who want to read and sign off on vascular studies, which has become especially important in terms of reimbursement. So to your point about the difference between Europe and the United States, state to state, there are some differences. Here in New Jersey, several years ago, it was deemed that basically a nurse practitioner or physician assistant could perform essentially any procedure that the supervising physician could perform. So as long as I am certified and properly credentialed to do a particular procedure, theoretically, Beth could also do that same procedure under my supervision, not necessarily direct supervision, but general supervision that I'm available, et cetera. The problem with that is not so much the state allowing you to do it or the clinician's ability to do so. In Beth's case, she's capable of doing all of these procedures. She has many years experience. Sometimes the stumbling block becomes in reimbursement, that although she has every right to do so and she's trained and certified and allowed to do that, that doesn't mean that an insurance company would pay for it. So many times, in my practice at least, I do many of the more invasive procedures only so that we can make sure that we are being reimbursed and that we don't do anything unscrupulous, like have somebody do something and sort of pretend that somebody else is doing it, which can go on out there. And that's one thing for our listeners, our patients especially, to look out for. So we never cross any such boundaries, but I can assure you Beth is very well trained and capable in doing endovenous ablation, microphlebectomy, ultrasound-guided sclerotherapy, all of those things. And she's had wonderful training and wonderful experience. And she's worked with, interestingly, because she's had several positions over the years, she's worked with general surgeons, vascular surgeons, interventional cardiologists, and interventional radiologists. So in a way, she's had really quite an amazing exposure to specialists in this area who come to it from different backgrounds and training paradigms themselves, which I think is valuable, actually.
But maybe right now it will be good for our audience if you could say us what is the, in your experience, part of the lymphedema practice in the vein lymphatic clinics, and particularly in the place that you worked before and now with John Chuback.
What is my role? Is that
what is what is the proportion of the lymphedema patients that you have, more or less, and what is your role in the treatment of those patients?
So, and Dr. Chuback can correct me if I'm wrong, but I think we probably have somewhere around 30% lymphedema patients in this practice. Would you agree?
Well, generally, historically, I would have said yes. But now, as my eyes have been opening through the Lymphcast podcast and our guests and our educational experience that we've been getting in the last several years, it's likely significantly more. If we consider that anybody with edema and venous disease, now we really consider to have lymphedema, phlebolymphodema, then I would say that it's all of our patients who are class 3 and above patients. So in that regard, I would say it's probably maybe 50 to 60%, maybe even more, even if you're talking about mild swelling. But yes, I would agree with Beth when she says, based on our sort of previous understanding of lymphedema, where it's quite obvious clinical manifestation with swelling of the dorsum of the foot and squaring of the toes, and a more advanced lymphedema state where there might be a history that would be more suggestive of the kind of old paradigm of lymphedema, groin dissection, trauma, iatrogenic, or congenital, then maybe more like 30%. But now our definition of that pathology, I think, is ever expanding.
Yeah. So to answer your question, in our practice, because I am a nurse practitioner and Dr. Chuback is very busy all day doing all of the larger vein procedures, I tend to see the patients first at their initial consultation, and I interview them and take their history. And I have the privilege and luxury of spending a tremendous amount of time with the patients at that initial visit. And I really go into detail, not just getting a detailed medical history, but also a detailed social history to get a really good idea of what are the barriers that they may have to self-care, to performing personal hygiene, to donning a compression stocking, performing skincare. Do they live alone? Do they have a caregiver support? And then I spend a tremendous amount of time educating patients about lymphedema, about how to care for themselves, about how to prevent cellulitis and complications, as well as how to don compression, physically demonstrating to them how to don compression devices using donners and doffers and how to perform skincare, and there are a lot of obstacles that they have to overcome. Many of our lymphedema patients are morbidly obese. Sometimes they have multiple comorbidities. And so I spend a lot of time with them teaching and trying to identify tools that they can use to perform self-care.
Well, that's extremely important, and what I really think that it's certainly crucial is to management of all comorbidities, as you say, because they certainly, the obesity is terrible for patients. They might really worsen the condition of lymphedema. It leads to many complications, right? And so you are the first seeing the patient, and do you have is that very frequent situation? You have a hinge of the diagnosis for the patient coming with some trouble, and they don't know still what is that.
It's interesting. We get referrals from a variety of providers, primary care physicians, podiatrists, orthopedists, who send the patient in simply with the leg swelling as, the chief complaint.
Yes. Yeah.
And I can't tell you how many patients I have seen who come in and they're complaining of a swollen leg and they have never heard the word lymphedema before. And so for many of these patients, they've been hopping from provider to provider, desperately looking for a name for their condition and some sort of tangible support and treatment that they haven't been able to get. And very frequently, I'm the first person that's ever said the word lymphedema to them. And they're overwhelmed with emotion to finally have a name of a condition that they can look up themselves and start investigating. And when I start telling them, here are some of the treatment options that we can offer you, some of them weep. It's really an emotional situation for them.
Vein Formula 1000 and Lymphatic Formula 1000 from VitaSupport MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
Yeah, we have heard of many patients, wandering from one physician to another for years before getting the proper diagnosis. That is a problem.
Yeah, it's really a great point that Beth brings out, because before they weep, usually tears of joy, before they even know whether that's good or bad. They're just so happy to know that the problem has a name. It's a real problem. They're not crazy, and that their quest for answers has finally culminated in a place and with a person who can put a name to the problem and give a diagnosis. It's such a relief to know at least that this is a real disease. Then, of course, they feel very much more relieved subsequently to find out that there are things that we can do to help them, depending on what the cause is. No matter what the cause is, there's always something we can do to help with their lymphedema. And then it becomes that process of deciding, is it phlebolymphodema? Is it from superficial disease? Is it deep system? Is it a combination? Is it obstructive? Is it post-surgical, et cetera, et cetera, et cetera? We can cross all of those bridges later. But as Beth says, very rightly so, they literally often weep to know that finally somebody knows what's wrong with me. As I said, ironically, even before they know if that's good or bad, like it could be, oh my God, this is a terrible diagnosis. But before they even get to that stage, they're just so relieved to feel like I'm finally in the hands of someone who knows what's going on and understands this.
So, Beth, your diagnosis, first when you see the patient, you examine the patient, you have the all history. But your confirmation of the lymphedema diagnosis is what? Just clinical, or do you advise with Dr. Chuback some complementary examination to.
Yeah, no, I don't think that we have a final diagnosis until they've completed really a 3-step process. Okay. I'm the first step in that process where I'm the information gatherer, and I'm very good at gathering information from patients, and I try to get him as detailed a history as possible, and really look for all of the risk factors, all of the comorbidities, any potential primary causes of lymphedema or secondary causes. And then the patient has a complete ultrasound so that we can see whether there's any venous insufficiency or obstruction that might be contributing to the edema. And then the third component of their consultation is that they meet with Dr. Chuback, and I tell him what I've found and what I've learned about the patient, and we pull it all together and come up with a final diagnosis.
That's a wonderful process that the patient appreciate a lot. They are going with you and having the confirmation of diagnosis, and then the opening for the follow-up, right?
Yeah, I think we spend a tremendous amount of time with our patients. We just talking to them and getting to know them and really getting to the heart of the problem.
And I have the question for both of you, because this is a totally almost philosophical discussion, like.
Monica, before you get to that question, can I just mention one other thing that's important? Based on this previous conversation, one other very important thing to point out. So many patients who do get evaluated elsewhere by I call us now sort of super subspecialists, because I would consider a surgeon a specialist, a vascular surgeon a subspecialist, and then a venous professional a super subspecialist, okay? To the equivalent that you might have a patient, an ophthalmologist who's a retinal specialist or a cataract specialist. You're really a super subspecialist. So being a super subspecialist, it's easy to be good at what you do because it's all you do. So I think maybe at times we tend to criticize our colleagues for not making these diagnoses and so forth. But then again, I probably don't know that much about retinal disease either. So I think it's important that these patients do get more and more referred to super subspecialists like ourselves. The problem, and it seems like such an easy thing to do, but the problem is that many of our colleagues, and this is where I do get critical, I don't try to diagnose retinal disease or visual problems at all. I don't try to differentiate a cataract from a retinal problem or glaucoma or whatever it is, macular degeneration. I don't even attempt to do so. I say you need to see an ophthalmologist to be evaluated, and that ophthalmologist can then get you to the specialist. But too many of these patients, they don't come saying that I came here with this swollen limb or these swollen limbs, and my doctor told me he or she doesn't know what's wrong with me. That would be okay. But what they come saying far too frequently is, everybody tells me there's nothing wrong with me. That's a big difference. They say that you're okay. I went for an ultrasound. I don't have a blood clot. They told me my ultrasound is normal. There's nothing wrong with me. I'm okay. They all telling me I should just elevate my feet at night and lose weight and don't take excessive salt. So that's why there's such a great sense of relief, because the patient knows intrinsically that they're sick. They know there's something wrong with them, and they're being told by everybody, you're okay. There's nothing wrong with you. We got an ultrasound. It's normal. And so they start to feel, quite frankly, crazy, and they start to feel frustrated and confused. How could I look this way and feel this way? And all of these doctors are telling me, not that they don't know what's wrong with me, not that they don't understand the problem, not that I should go get another opinion, not that they're going to help me to understand this, but that I'm okay, that I'm not sick, there's nothing wrong with me. So that's part of the reason why it's such a massive, massive relief to these people, because they're starting to feel crazy, having gone to many physicians for years, being told there's nothing wrong with you. And so especially, and that's for our listeners, physicians who are non-specialists, our patients, because we always have to remember we're talking to the listeners, not just to one another. An ultrasound examination of the lower extremity for edema should not just be limited to rule out DVT, to rule out a blood clot in the deep system. There are many
Amen
other.
to that, John.
What's that?
Amen to that.
Right. Yeah. And that's one of the huge educational barriers that we have to overcome in the evaluation of the swollen lower extremity or upper extremity, whether it's unilateral or bilateral. Physicians need to really think, of course, DVT is a potentially life-threatening diagnosis, so it needs to be ruled out, no question about it. But we also have to do a much better job in educating our colleagues that there are diagnostic exams, including many related to ultrasonography, that go far beyond rule out DVT, and they should be looking for superficial venous problems and especially functional venous problems. And we can't blame them for not knowing that, because they simply don't know. And we have to get the word out. And we have to continue to have these kinds of programs, educational seminars, et cetera, to let our primary care colleagues and even our vascular surgical colleagues, general surgical colleagues, et cetera, know that there's more to venous ultrasound than rule out DVT. A lot more to it. And we'll make a lot more diagnoses a lot earlier and have A, happier patients, but B, patients who get treated much earlier in the clinical progression of that disease, and hopefully save a lot of extreme swelling scenarios.
John, if I can ask you a quick question, how often are these patients, before they get to you, how often are they told, it's all in your head? Like you said, just go put your feet up, quit eating so much, and there's a lot going on in your head. Just go home and have a good stiff drink and go home.
Yeah, it's not necessarily, Paul, I hope I didn't misportray it. It's not typically that the physician or the nurse practitioner or physician assistant would say to them, it's all in your head. What they because they can see that they have a swollen limb. Yeah. They can see that they have swollen legs. But they're basically saying it's no big deal. Whatever it is, right? If it's not going to kill you, you don't have to worry about it. But the individual is saying, well, that's easy for you to say. You're not dragging around a big swollen leg, or you don't have two big swollen feet and ankles that don't fit in my shoes any longer. I'm relieved to hear, doctor, that you don't think I'm going to die from this, which generally is correct. But I'd also like to know what I could do to get better. And then typically, or very frequently, that conversation sort of progresses to the patient being put on a diuretic, a water pill, to get rid of excess water in the body, which is obviously not the correct answer. And we've talked about that a lot on this show. So they get put on a water pill and they get a little bit better, but not much better. And they're still frustrated. So when I say they start feeling kind of crazy, it's not because somebody's telling them they're crazy. It's just because they've seen several people. They've seen a cardiologist. They've seen an internist. They might see a nephrologist. They might see a liver specialist. They might see a podiatrist. They might see all of the above. And everybody tells them, don't worry about it. But when you're swollen and disfigured and uncomfortable, you worry about it.
Yeah, I think you are absolutely right. It's not a question that their swollen legs are denied by the physician, but they are put in the situation like it would be desperate. No other solution that elevate your leg and lose weight. Well, elevate your leg when people have to work, they are out all the day. How do we elevate the legs in the office? It's really certainly the very complex psychological situation for those people. Yeah.
Right. And to Beth's point, in our practice, which is rare, and there's a price to pay for this, quite frankly, we spend a lot of time with the people. She spends a lot of time in that opening, interview and physical examination, history and physical. And most physicians today simply do not have the time to do it. So if somebody shows them swollen ankles, showing somebody swollen ankles would be like somebody showing their dentist that they have teeth. I mean, they're so common that people are not going to be impressed by it unless it's extreme, unless you have a really extremely swollen, particularly one limb, not both, but one side or the other, then the physician or practitioner will be very concerned that the patient might have a blood clot and it could be life-threatening, and then they order an ultrasound. But beyond that, swollen ankles really don't impress primary care doctors because they see so many of them for so many different reasons. And that, again, I think that's a very important word that Monica made me think of. The patient feels that they're being dismissed, that their complaint is not worthy of attention or worthy of investigation. So it's just like, yeah, I see that you're swollen, I get it, but I don't care, and that's really what they're hearing. They're hearing the physician say, I don't care, because unless you're going to die from it, I have more important things to do. And that's a terrible feeling. And unfortunately, I think that we've gotten to the point in healthcare in the United States where everyone is so busy and overworked that we're getting a lot of that, not just in that particular scenario, but in general, when people have aches and pains and this and that, various things. If you don't, come in with, a blood pressure of 275 over 160, and the doctor's afraid that you're going to have a stroke in his or her office, they're not really too concerned. It really has to be something that's a red light flashing today for you to get anybody's attention. And swollen ankles generally aren't going to do it.
And if I can interrupt for a second, it's interesting because a lot of the primary care physicians have treated these patients for recurrent cellulitis over and over and over. And when the patients ask them, well, what can I do? And the only answer they're getting is lose weight. But that's a long-term goal. In the short term, patients need to know how to care for themselves to prevent cellulitis from recurring, and they don't get the tools to do that. And so they're almost shamed by being told, this is your own fault. You've done this to yourself. You need to lose weight. And until you do that, no one can help you. So it's a terrible predicament for them because they need short-term answers and short-term help.
Yeah. John, would this be a good time to just take a break for a moment? We have a new segment, the Lymph Lighthouse segment. We encourage our listeners to write in. If you have a question for any of the panel, hello@lymphcastnetwork.com. Is it okay if we take a few moments to ask a few questions?
Yeah, I think that's a great idea. And I think I should probably try to explain a little bit the name of the new segment, the Lymph Lighthouse. Yes. I think the Lymph Lighthouse, which one of our team members came up with, not me, but I think it's a terrific name once I kind of understood it a little bit better. I think the Lymph Lighthouse has kind of a double entendre kind of meaning associated with it. One is that it's a beacon of light, a beacon of hope, so that for anybody who may be out there experiencing the kind of emotions and situations that we're talking about, who might feel proverbially that like their ship might crash into the rocks, or that they're kind of lost at sea in the dark. And I think the lighthouse is meant to be a beacon of safety and hope, and help refocus and redirect some of our listeners who may be feeling lost in this whole process for one reason or the other. And then, of course, the lighthouse hopefully will shine some light on the problem and help to illuminate things. So I think it's a very nice name, actually. And so that is our new segment called the Lymph Lighthouse, where we're going to be answering questions that our listeners email to us to the best of our ability.
Okay, let me start off with Beth. Beth, we have a question for you to kick this off. Since you're the one who meets the patients first, it sounds like, at least at the medical level.
Since you're the smartest one.
Well, you're all pretty brilliant, so I think anybody could handle it. But we'll start with Beth, since she's the guest. What are the common symptoms of lymphedema, and how can a patient recognize them? If they're home alone, what can kind of trigger, hey, I might have lymphedema, I'd better get in?
So, lymphedema is a chronic progressive disorder, and it's not the kind of thing that you're going to wake up in one morning and say, my leg is swollen, I think I have lymphedema. If it's acute swelling, I think you would probably suspect that there was something else going on. Lymphedema patients have typically had slowly progressive swelling over a many-year period, or maybe they've had a surgical procedure performed and then had swelling that developed after that surgical procedure. So I would say leg heaviness, leg swelling is the first thing that you would notice. And typically that resolves overnight in the beginning, in the early stages of lymphedema. As the lymphedema progresses, the swelling remains and doesn't resolve overnight. And so no matter what you do, no matter how much you elevate your leg, the leg is still swollen.
Okay. Yeah, that's a perfect answer. That makes a lot of sense to me as the non-physician person here. So if I understand it, I know you folks do as well. Dr. Levitsky, the next question is for you. Are there specific risk factors that increase the likelihood of developing lymphedema?
So certainly some surgical procedures are bringing a risk of the damage of lymphatic and certainly very well known that there is a lymphedema after the breast surgery, lymphedema of the upper limb. Other risk factors are obesity. Obesity is frequently actually going both sides because this is a risk factor, and this is also might be related with the complicated cases of lymphedema. Other than that, you have the genetic etiology of the primary lymphedema, and you have in some families you have the systematically appearing the new cases of lymphedema, which is known. Mother had the same situation. Daughter, maybe the new generation will have that risk too, and this is related to some gene mutations. And you have a huge number of patients which have the so-called phlebolymphedema, so the lymphedema related to venous disease, and that's certainly very frequent among the vein and lymphatic clinics such as Dr. Chuback's. And in the other parts of the world, you have a huge issue with the lymphatic filariasis. So this is the disease related to the parasite infection, which is correlated with the extremely spectacular cases of the lymphedema. But probably in the United States, we don't have that basis.
Okay. Last question for you, Dr. Chuback. If a patient has lymphedema and we don't know what level or to what degree, but can they travel? Can they take long car rides? Can they take plane rides? If they want to go from your office to Dr. Levitsky's, New Jersey to Arizona by car, can they do that? And if so, what precautions can they take?
Yes, generally people with lymphedema can travel quite safely. There may be some discomfort associated with long bouts of travel because the lower extremity, for example, is in what we call the dependent position. It's below the level of the right side of the heart. So gravity is going to tend to pull fluid and trap fluid in the lower extremity and particularly at the bottom of the lower extremity. So generally, you'll see swelling in the not only the leg, the lower leg, but also the foot. So this is very common diagnostic sign of lymphedema when you get swelling on the top of the foot, what we call the dorsum of the foot. It almost looks like a muffin top, we call it. So that can cause pressure and discomfort for the patient, although very little danger, generally speaking. And they would do things like wear a compression stocking, graduated compression stocking while traveling. Knee high is typically adequate in most patients for travel, but even a thigh high compression stocking may be superior in some patients. Also, we encourage people to activate what's called the calf muscle pump, whereby if this were my calf and this or my foot, we ask the patient to flex and point the foot, or dorsiflex and plantar flex and extend the foot to pump the calf muscle, which evacuates not only venous blood from the leg, but also that muscular contraction contracts and squeezes all of your smaller lymphatic channels, which will push fluid, excess fluid and lymphatic fluid out of the limb and help force it back toward the heart. So those are things, if it's a car ride, we also suggest that every reasonable period of time, an hour to an hour and a half, you might stop the car for a coffee break or a restroom break, and also get out of the car and walk around for a few minutes, because then you're forcing all of the big muscles in the lower extremities to work and also push fluid back to the heart. On an airplane, if you're in a position to elevate the legs, that's great. If you can walk in the aisle once in a while to stimulate flow, that's great. The compression stockings are great. And of course, we always recommend the vein formula or lymphatic formula, which has the micronized purified flavonoid fraction, the MPFF, that's that bioflavonoid complex that comes from citrus rind, the natural dietary supplement, which we believe, based on lots of research that's been done over the years and Dr. Glowicki's good work, promotes lymphatic flow and helps the lymphatic system to work at its very best. So those are some of the basic tips and fundamental tips. And I encourage people suffering from these problems, obviously, to listen to our program as frequently as possible, because we go over many of these ideas again and again. And as I always say, repetition is the mother of education. So we'll be hitting on many of these important questions over and over.
Yeah, very well said. We have 30. This is episode 30, so lots to listen to, lots to watch. And before we get back into the questions and back to the panel, a reminder to our listeners, go ahead and write us, and the panel will address your question. The email address again, hello@lymphcastnetwork.com. Again, that'll be in the show notes. And Dr. Chuback, I'll turn it back to you and continue on with the discussion.
Well, thank you, Paul. Now that you say that, you're giving an email address. There's another email address that I think is critical that we always remember to share. I'm noticing behind Dr. Glowicki, if anybody's watching our YouTube version of this, our vodcast, as opposed to our podcast, she has a beautiful new painting that she's working on of a surgical scene. I think it may be for a textbook or something like that. She can explain it to us. But Dr. Glowicki is a very accomplished fine artist and painter. And Dr. Glowicki, if you could share your website with our listeners, I would appreciate that. And I'm sure they would appreciate that, to see your work.
Oh, thank you very much for the opportunity. Yes, if somebody is interested, my website is Monica with K, L, this is my middle name, Glowicki, GLOVICKI.com. You can find my work website.
MonicaLGlowicki.com. And I'm sure we'll post that as well. And you'll be able to find the link to that on our website, the lymphcastnetwork.com. But beautiful, beautiful painter. And as you can see, she can do beautiful representational figurative work, as she has there. In fact, in my own personal collection, I own one of Dr. Glowicki's paintings of herself as a little girl, which is a beautiful, one of my absolute favorites. But she also does some phenomenal abstractions, and color is one of her. The use of color is one of her great strengths, and something she's studied quite a bit over these years. So I encourage everybody to check that out.
Well, you're an artist too, aren't you, John?
A bit of an artist. I had some training, and I dabble, but I wouldn't call myself a professional like Dr. Glowicki.
Okay.
Still working.
Well, you're good, though.
Thank you.
You don't need to be professional to be good.
Thank you very much.
But you are an author. You might want to put that out there. You have a lot of books out there.
I am an author. Everybody can go to chubackeducation.com to check out my books. And the latest book that Paul and I are working on a podcast, Your Blueprint for Success, which is a wonderful book about personal development is available at Amazon. But after all that, let's get back to some questions for Dr. Beth Coll, our nurse practitioner, and my colleague here at Chuback Vein Center. Monica, I think before we got down that big road, you were about to ask something a few minutes ago.
Yeah.
At VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
Yes, absolutely. This is almost, as I said, a philosophical question, because truly, most of the cases, you have a very clear situation after the clinical examination and the duplex examination ruling out, some other pathologies. But my question is, do you often prescribe to your patients a lymphoscintigraphy, which is in all guidelines pointed out as a diagnostic criteria for lymphedema?
Beth, she's asking you if you
I would have to.
I want to answer this question myself.
I would have to punt that question to you, because I'd say that the advanced imaging orders come from Dr. Chuback.
Yeah. So the reason I'm asking, because it was very recently one publication that pointed out that although this is like the confirmation of the lymphedema diagnosis, only 2.5% of patients are having this confirmation. So what do you think, John? Should we? Because this complex examination, not every center has, like hospital center, vascular.
It's a fantastic question. And I don't think it's one that we've discussed before on the program. I have to admit that I essentially never order the test. Now, that may not be right. I'm just telling you what my clinical experience has been, and I can give you the reason why, or the reasons. As you just touched on, generally speaking, my experience was, now this is going back, a fair number of years, but my experience was during my training, general surgery and cardiovascular training, that the study was being very, very rarely performed at that time. And so there were very, very few people, my understanding again, I can be wrong and I can be corrected, but my understanding was that it was very much operator dependent, and that most centers, even big academic centers like I was in during my training, were not doing a good job with lymphoscintigraphy at all. And secondly, but more importantly, because could I find someone doing excellent lymphoscintigraphy in the New York metro area? I'm certain that I could. If I go to Columbia Presbyterian or Mount Sinai or NYU, or even locally, I don't know, Hackensack Medical Center, one of our local hospitals, Valley Hospital. If I searched it out and I really needed it done, I'm sure I could find out who's sort of the best with lymphoscintigraphy in terms of performing it and evaluating it. The reason that I haven't done it is because I think generally my personal clinical belief has been that, generally speaking, I'm not seeing the sort of
like primary lymphedema
cases, filariasis, some kind of obstructing tumor, post-radiation, someone who I feel would be a candidate to benefit from surgical repair, lymphovenous anastomosis, or lymph node transfer, or some of these more complicated things. Generally, what we're seeing is bread and butter secondary lymphedema, secondary to, in my case, almost exclusively phlebolymphedema from chronic venous insufficiency, whether superficial or deep. And I think that we're treating it clinically in such a way that the vast majority of our patients get, wonderful response to care, especially when they are compliant and dedicated. So certainly, I think to order lymphoscintigraphy in all of the patients I see with lymphedema would be a gross abuse and overutilization of the test. But I'm open to your perspective on it. I just, that's kind of how I've functioned.
So no, but I think I agree with you. There is in your particular situation, there is no need. The fact is that maybe in the future we would need a little bit more elaborated examination specific lymphedema, which we are not yet in this situation. There is a research ongoing, not yet clinical with the precise diagnosis.
Yeah, I think that's exactly right, because I think, again, as a clinician, as opposed to a researcher or a study situation, when you're seeing things that are common and manageable through the normal routes of good clinical medicine, whenever you order any test, you sort of have to ask yourself, what will I do with the results? And that's why, as an example, patients who come with venous insufficiency and a swollen limb, and they have all of the stigmata of chronic venous disease in the superficial system with saphenofemoral pathology, etc., it would be the same idea why we don't go ahead and get an MRV of all of those patients, for example.
So maybe let's continue a little bit with the Beth work as a nurse practitioner working with the lymphedema patients, and I would like to have your opinion. What are the most frequently encountered obstacles in the case of lymphedema patients?
Well, I think that there are the patient's individual obstacles, like we talked about a little bit about before, social barriers, living alone, not having a caregiver to assist them, especially with our patients. We have a fair number of patients that are morbidly obese, and they have limited mobility and can't don a stocking, can't perform hygiene, can't apply an ointment to their legs. So those are personal barriers that most of our patients encounter. And sometimes we have to work with them to get them assistance. I've had patients come in who have acute cellulitis and dermatitis and blisters and ulcers, and they usually necessitate a consult with the visiting nurse agency so that we can get them into a multi-layer compression dressing 3 times a week. And equally as important, they can also then get them a social services consult and get them access to a social worker who can maybe provide them with greater assistance from within the community with transportation, with a home health aide, just helping to identify their other needs by going into the home and seeing how are you caring for yourself? How are you able to take care of your legs? How are you able to bathe? And it's kind of surprising sometimes to find out that people don't have access to those basic needs. And so that's a very important component. That's what I see as a patient's personal barriers that we need to help them overcome. And then from a more universal perspective, there's a shortage of lymphedema therapists. There just aren't enough lymphedema therapists to go around. They're not available. We are very lucky to have a couple of excellent lymphedema therapists in our area, but they're few and far between, and they don't accept or participate with all the insurance companies. So, there's a lucky handful of patients that get to see those therapists, but most of our patients don't have access to a qualified therapist for decongestive therapy. And we have to use our other resources like home lymphedema pumps and compression wraps. So access to care, and personal challenges, I think.
Yeah, I think it's an excellent question. I'm sorry, Monica. I was just going to say that was an excellent question. And I think we try here at Chuback Vein Center to advocate for patients, but having somebody like Beth who can spend the time with patients at their initial consultation and later, she spends a lot more time in caring for patients, doing sclerotherapy, follow-up appointments, wound care, Unibut application. But, it's essential that we have all levels of clinicians acting as advocates for these patients in terms of raising awareness, educating, and then creating those lines of access to the resources that may be available in a community, whether those are wraps, compression devices, pneumatic compression pumps. I mean, again, I'll put in a few plugs for some of the folks who've been on the show and have supported the show. A LymphaPress type pump, getting patients access to those. The good folks at Omni Therapy here in Nutley, New Jersey, who've been for 30, 35 years doing hands-on therapy, manual lymphatic drainage, compression therapy, et cetera. And there are folks like that all over the country. And if you're one of them and you're listening, please, send us an email, tell us about your practice. We'd love to have you on the program. We'd love to shine some light on you. If there are other resources you're aware of that patients have access to, please share those with us. We would love to hear about that. But I feel like at some point in every show, I get to the point where I make this same statement. This is a really complex problem. This is a really hard problem. It's not an appendectomy. I wish all of medicine were an appendectomy or a hernia repair, but this is not one of those problems that can be treated and cured in one session. This is basically a lifestyle of care. It's a chronic progressive disease, as Beth pointed out earlier in the program. It's incurable, but it's treatable and it's manageable. But unfortunately, that management is a multimodality, multimodal, multidisciplinary treatment strategy that includes diet, exercise, dietary supplementation with supplements like MPFF, compression, elevation, surgical intervention, non-surgical intervention, hands-on therapy, psychological, emotional support, et cetera, et cetera. I mean, it's really a complicated problem. And it also, I think, sheds light on a subject we talked about earlier, which is it's why so many physicians, when they see it, they want to avoid it because it's so difficult to treat. It's so difficult to manage. It's time consuming. It requires many resources from the doctor's office if they were going to try to really pursue this kind of care. And you hate to say that, but we're in a system where it doesn't pay for the doctor to get too involved. So unless it's life-threatening, they dismiss the problem and patients suffer. And that's a big part of our work is to try to help avoid that.
So I think that certainly, like the treatment, as you said, it's very complex. And there's out of the question the general physician to be able to provide with that complexity of the treatment. And I think that the much more importantly, I see this space for the self-care for those patients. And in this aspect, certainly, Beth, you have absolutely unbelievable role because nothing is easy, nothing is simple, but you can guide the patient. You can introduce them to many modalities like they can learn to a certain extent a relatively good quality self manual lymph drainage care if they cannot afford the specialized therapist. And there's many things that they can do. They just have to learn about it and follow the road. Certain. I don't know. You certainly have the much more experience how to guide them and how to overcome all those obstacles that we were talking about.
Yeah, I mean, if you give patients the tools to help themselves, they use them. And, I've seen patients come back a year later and their edema is well controlled. Their skin is in excellent condition. They're putting their stockings on and off. They're using their home pump and they're new people. Their personality is completely changed. And they walk in and they're so proud of themselves and they say, I figured this out. I've learned how to manage this. And, this has changed my life. So, yeah, I think you need to be able to identify the tools for those people. And sometimes it's trying 5 or 6 or 7 different types of compression garments and staying in the room with the patient and showing them how to put it on yourself and then showing how to put it on them and then watching them try to put it on. And after a half hour of this, they still fail. And you say, okay, we'll try another method.
Yeah, it's a great point. And, Monica, we often, I often get on this subject and soapbox, and I think, Paul, probably we're coming near the end of today's program, right? So maybe we'll kind of wrap it up here in my paying a wonderful compliment to Dr. Beth Coll, advanced practice nurse and doctor of nurse practitioner, my nurse practitioner here at Chuback Vein Center. I often say that many years ago when I first got involved in venous care, and I went to some of the early courses for training and so forth. One of the early courses I took was a venous ultrasound course with Joe Zygmunt, and I'm sure Monica knows Joe very well. And one of the things, Joe, there's a lot of information passed in those sessions and seminars, technical things and lots of, again, knobology, how to use the machine and holding the probe and the different frequencies and physics and lots of kind of highbrow, complicated stuff. But the thing that Joe Zygmunt said that day that has always stayed with me and I pass along to others who I've worked with and taught along the way is that if you want to be a great ultrasonographer, venous ultrasonographer, you have to be curious. You have to ask yourself, I wonder where this vein originates. I wonder where it goes. I wonder where that reflux is coming from. I wonder why the reflux that I see here, I can't demonstrate there. I wonder why. I'm curious. And if you're curious about things, and if you let your curiosity lead your exam, you'll be much more likely to make a more thorough assessment of the patient's vascular system and a better and more precise and more valuable diagnosis. But there's one step beyond that Joe didn't say that day, but I've kind of added to that great lesson, which is, well, why would somebody be curious? And to be curious, you have to care. If you don't care about the patient, why be curious? Right? Just do a cursory exam, write down what you find, do the basics, do the minimal amount required, jot down the numbers and call for the next patient. But someone like Beth Coll really cares. That's why she was a great nurse when I knew her 25 years ago. And now she's a great nurse practitioner and she takes great care of patients because in everything that she does, as every good practitioner should, she cares. She cares about the patient. She cares about how the patient is feeling. She cares about the patient's circumstances. She cares about the patient's access to care. She cares about all the things you're supposed to care about to be a good, doctor, quote unquote. And I say it again and again, we've got to get more back to caring in this country when it comes to health care than tests and money and reimbursement and insurance. And not that those things aren't important. They're all important. But if our healthcare system doesn't educate young people to care about other people, we're in big trouble. So I feel fortunate to have somebody like Beth. Not somebody like Beth. I feel fortunate to have Beth working with me.
The real Beth. You got her.
The real Beth.
You have this privilege. Right?
A great privilege.
Thank you very much.
So I think that's kind of a good place to leave it.
Yep, I agree. If you'll take the honors, Dr. Chuback, of thanking Beth, since she is working in your office, and I'll address the other two people on the panel. Just go ahead and take care of Beth.
Beth, if that wasn't enough, I want to thank you again, because Paul says I should put a cherry on top of that ice cream sundae I built to you.
Well, thank you. I really, this was a lot of fun. I really enjoyed participating. So thank you for inviting me.
Thank you. It's a privilege to have you. And I think that we're going to have you back and see a lot more of you on the show, because I really do think you added a very, very important, valuable dimension to the discussion that we could use more of. And I'll have Dr. Glavitsky say goodbye, and thank you, Dr. Glavitsky.
Thank you very much for having me, and looking forward to the next episode.
All right. I should say one more thing, Paul. Our dear friend, Dr. Eicher, unfortunately could not make it today. She had a last-minute appointment that she had to attend to. But I want to mention also for Dr. Eicher, for anybody, especially in the West Coast area, California area, Santa Monica, California area, Los Angeles, etc., lymphedemacenter.com. Lymphedemacenter.com is Dr. Eicher's website. Learn more about her, and if you have questions or need a consultation, virtual consultation, or any of those things, please reach out to Dr. Eicher. She's really one of the most renowned lymphedema specialists in the United States, and we're fortunate to have her on our program.
All right, very well said. We also want to thank you, Dr. Chuback, the creator, founder of this show, also the creator and founder of VitaSupport MD, makers of Vein Formula 1000, Lymphatic Formula 1000. From New Jersey, physician surgeon, Dr. John A. Chuback. Dr. Chuback, thank you for everything.
Always a pleasure. Thank you, Paul.
Oh, you bet. And we want to remind our viewers and listeners, check out our website, lymphcastnetwork.com, and send in your questions, and the panel will address them on the show. And that email address again, hello@lymphcastnetwork.com. In the podcast world, we are everywhere. Apple Podcasts, TuneIn, Stitcher, Spotify, Audible, everywhere you can find a podcast. Just type in Lymphcast and this show will come up. And we're also on YouTube. And we thank you again for watching Lymphcast episode number 30. Have a great night.